In other words, it's a near universal human experience to be anxious or depressed. This is an understandable response to things in your life. It's meaningful. It's telling you something is wrong with what's going on. It's important. In the same way you wouldn't cover up a warning light on your car dashboard. If you're thinking you need to change every aspect of your life, then maybe you should try that, because at the age of 21, you can do that. So daytime tiredness and impaired sleep and insomnia are all recognized side effects of antidepressants. So number one is emotional numbing, which I certainly had. This idea that emotions in your life are flattened, both positive and negative emotions. Sexual side effects are reported by more than 50% of people. Antidepressants, in all the studies that have been done, disrupt sleep architecture. They vary. We have stages of sleep, REM. It's well known that they will prevent REM sleep, which is why a lot of people don't dream while taking antidepressants. Physical dependence in pharmacology refers to the predictable physiological adaptation to a drug that occurs if you take a drug repeatedly. The same is true for antidepressants. If you use it for long enough, you develop physical dependence, and that puts you at risk of having withdrawal syndrome if you stop it. So it's very misleading to say that antidepressant withdrawal effects are brief and mild, because that's only true for people that are on them for a few weeks. Most people out in the community are on them for months, years, or sometimes decades. It has been very difficult to come off the drugs. So I tried to come off over 4 months, and it was probably the most distressing period of my life. As I said, I developed panic attacks that lasted for most of the day. I had trouble sleeping. A few weeks into that experience, I thought about killing myself, because it was just waking up to the same horror every day was unbearable. Most of the information that is in the guidelines that doctors read comes from studies done by the manufacturers of drugs. So more than 95% of studies of antidepressants and similar drugs are conducted by the manufacturers of those drugs, unless an individual doctor is putting in a lot of effort to look at the science directly, to look at it through a critical lens and look at what the slates of hand, the tricks are. They would generally get an overly rosy version of what these drugs do, and an overly rosy version of the side effects, and also the trouble coming off the drugs. There is no magic bullet for existential questions. The questions of who you are, what you should do. There is no shortcut. There is no tablet in my drawers that can help this. The only way through such problems is through them. There's no way around. And there'll be a lot of people that will offer you diagnoses with capital letters that'll sound very serious, but don't lose sight of the humanistic, obvious, understandable reasons why you're here. It's working out that will get you out of this. Going through coming off these drugs and the trouble it's caused me, and the near, life-ending trouble. The troubles that I had at 21 look piddling to me now. So, in a second, I would ask for double of that compared to what I've gone through. So if there is, I wouldn't wish it on anybody, if there is some lesson from coming off these drugs, it has made other negative things in my life look, minor by comparison.
Hello, my name is Beata Pawlikowska. I'm a writer, a traveler, and a journalist from Poland. I've been interested in neuroscience and neurobiology, health and mental health. And today, my guest is Dr. Mark Horowitz, who has a unique experience with antidepressants, both as a patient and as a doctor. Dr. Mark Horowitz was prescribed antidepressants when he was a student, then tried to come off the antidepressants, which he did too quickly, and then lived through the worst period of his life, as he calls it. He's an expert, and he has a lot of interesting things to say about antidepressants. Here's my conversation with Dr. Mark Horowitz. Our guest today is Dr. Mark Horowitz, a training psychiatrist and a researcher. He has the PhD in the neurobiology of depression and the action of antidepressants at the Institute of Psychiatry, Psychology, and Neuroscience at King's College London. Dr. Horowitz has also had his personal experience with antidepressants. So you are the rare case of being both the doctor and the patient, which I think is fascinating.
I suspect there's more than just me around, but yes, I've been in both seats, I guess.
And thank you for accepting the invitation. I'm sure it's going to be fantastic because you can see things from both sides. So I would like to start where it all began, when you were 21 and you felt like you didn't quite belong to the world, and you described yourself as a Woody Allen kind neurotic. What did you mean by that?
Yes, so I think he's fallen out of favor these days. So I come from a Jewish family, a very I guess a neurotic family. I don't know if it comes from having escaped the Holocaust a couple of generations ago, or whether it's just reading too many books or just too many worries. But I was definitely a pessimistic, ruminatory young man. Wasn't sure about my course. I hadn't fit in very easily to the Australian outdoorsy, sporty school that I had gone to. So for a variety of reasons, I was a miserable young man. And at 21, I went to see a doctor about it because I thought that was the right thing to do. That was what people around me were doing. And I was diagnosed with depression, and I was given an antidepressant that was being marketed widely in Australia at that time, an SSRI. I can't remember which one I was actually given, but I ended up cycling through a few of them because I had several side effects. And I ended up taking escitalopram, or Lexapro was the brand. And I took that for the next few years.
You were 21. Do you remember which year was that?
So
it was in the 90s?
No, I'm not quite that old. I'm 41 now, so it was 20 years ago. So it was
in the beginning of the 2000s.
That's right. Yeah,
right.
Exactly.
This is when the antidepressants, because they started to be prescribed widely in the 90s. So they were still the first thing to go to when somebody is diagnosed with depression. So you were 21 and you were in the third or fourth year of the university. So everything was kind of new about you, around you, and you didn't know where you would be going in the future, what life would look like. Do you think that it's quite natural to feel anxious?
Yes.
Being in that position?
So looking back on it now, I remember thinking at some point, I need to either change everything in my life. I need to change my course, my social group, what I do, how I think, or I've got a medical problem that I need to see a doctor about. And I remember being perched on the edge of that thought, do I need to change everything about me, kind of thing? Lost, I guess, in what I now see as an existential crisis. Who am I? What am I doing? Born out a bit of my early experiences at school, various pressures to do a certain university degree mixed with my inclinations. What I see now is an entirely normal existential dilemma. But I found that the prospect of having to do all these, make these changes, scary and overwhelming. And I guess that's why I elected to, go to the doctor and treat it as a medical problem, or seek a medical solution to the problem.
So what you didn't have was life skills. Yes. You were anxious, you were worried, you were alone, you felt lonely, maybe you felt an outsider or excluded, misunderstood, and you didn't have any coping mechanisms. Where can we learn them? If you said as your parents were neurotic too, so your parents could not teach you how to cope with stress or worry or rumination. So from your today's perspective, where can we learn this kind of skills, which are actually necessary? And this is like the most important thing in life, to be able to cope with the difficulties that come our way and will always be coming. There is no life without worries.
Yeah, no, I think that's a good point. I guess in the time since then, I guess I've matured. Although I've struggled against maturing, it's happened inevitably. I guess I have developed some of those life skills. I was much poorer equipped as a younger person. not to go into huge detail, but I mean, I think there were lots of things. I probably had a sleep issue. I was going to bed very late at night. I was getting up very late in the afternoons. I had that real teenage night owl kind of tendency. Since then, I've understood a lot more about circadian rhythms. I think that's really helped. That's been one of the big things that's helped me. I think inevitably I've learned, I've had a lot of positive social interactions, that was since that time, which has given me a lot more self-confidence. I think all those sort of things. I've chosen my environments more carefully. I think that when you're younger, you've got less control over your choices. So you're thrust into, these sort of catch-all places like school. As time goes on, you get to choose your social and professional group more carefully. I guess I've done a bit of therapy since then. I guess looking back, school had better equipped me to manage these sort of issues. That would have been a lot more helpful. I've developed things like mindfulness has been very helpful to me. I happen to be a lot into intermittent fasting, which I think has been actually very stabilizing emotionally. So I think there's a whole lot of things that I know now as a 40-year-old that I didn't know as a 20-year-old. It would have been very helpful to me. And I often, think back, if I had discovered these things at the age of 20, it would have set my life on a very different trajectory. I think another issue, which is the idea of shame. I was very ashamed about the things that worried me at the age of 20. It was very shameful to admit, that school hadn't been fun for me in ways that it had been fun for other people. And I think that a bit working through that, finding, I guess, safe social groups or, therapy, that has allowed me to a bit move through some of that shame, which I think is a big issue for young people.
So it sounds like you were a smart young man who did not belong to school and felt frustrated that other people take it easier. But you taking it a little harder was just to prove that you're thinking, that you are searching for something more meaningful, or you're searching for a better path. I'm asking because I can imagine some young people listening to us and thinking, wow, this is how I think. I'm like, I don't belong. I'm a stranger here. And perhaps feeling the way you felt, a little anxious or depressed. So what would you advise them? Where can they find something that might be helpful?
Yeah. I mean, I think what you're saying, it's a slightly positive spin on it, but it's, you're right. I mean, I felt a sense of alienation from the people around me as a teenager. I mean, I was young for my year. Yes, I was very intellectual. I was also probably, for all sorts of reasons, I came from a kind of an immigrant household. It was a second generation immigrant. They had slightly different values to what was at school. I was, we were a bit, one where it was a very bookish house. I was also very encouraged to, show the teacher I was very clever. So I was probably a bit of a know-it-all. Didn't quite.
Yeah.
Sometimes I joke that my schoolmates gave me important social feedback that such things were not encouraged. And I was a slow learner, I think, on that count. I had a big Jufro back when I used to have hair. So look, I think my message to young people in a similar circumstance would be, I think, as I've got old, I realized that alienation from your social group, is very common. There are a lot of, I took to reading a lot of books and watching movies that had similar themes. I think that's why I've been drawn to Woody Allen so much, because he's the sort of perpetual outsider, or, his character. And there are lots of different, I read Catcher in the Rye, 47 times at high school, like any disaffected teenage boy while smoking a cigarette. I think things change. I'm not, at the age of 40, I'm not the same person I was at 20. There's different groups of, people that I've encountered. So I guess my message would be, things get better. Seek out. I think there's I'm often seeing people in the emergency department who are suicidal, young people. And my message to them is generally, I've seen people who come in, they're wearing a rock t-shirt, their mother is wearing, religious garb, and they're talking about everyone at school being into sport. I say, you've got a cultural mismatch. You need to find rock people that are wearing similar T-shirts, and when you do, you're going to feel much more a part of things than you do now. I think it's about finding a non-shaming social group is the key thing for a lot of people.
Would you agree that sometimes it may be enough to realize that the way you are is just the way it should be? You don't have to be like everybody else. You don't have to belong to a group of people because you're an individual. You're special. You're exceptional. You have something special to do. Because you can either seek people who think the same or similar, and you can identify with them, or you can stay on your own. I mean, you can be like the Beatles and create a group, or you can be like Elvis Presley and be an individual, and do it on your own. Do you think it's possible?
Yes. I partially agree with you. I think, of course, everyone is an individual and everyone has strengths and weaknesses. I think, people, especially young people, do generally need some kind of a group, to feel a part of connection. Exactly. It doesn't have to be, people at school. It could be, people have very strong connections to writers or artists or things that they find. I think we all need something to reflect back to us that we're okay. It's very hard. Some people have incredible self-confidence that comes from within. I think we all need some kind of positive influence around us. It could be family, it could be a relative, it could be a friend, it could be an older person, it could be a mentor. I think we need generally something. And I think it's quite hard. There's probably the rare person that can, but it's quite hard to survive completely without that. But there are lots of different places to find such support. So I think, I accept your point, people are, very unique, and not everyone fits, certain people fit into the kind of generic culture of school or university. I think it's important to go look for places where you fit in. And that's important for giving people a sense of connection and meaning.
If I might add to that, because I was the most lonely person on the planet, and I didn't have anyone I could identify myself with. So I found my group, my social group, in biographical books. So I was reading about people I admired, and I got inspiration from them. So that was the group that I found that I could somehow identify myself with, because I didn't know anyone who could be friends with me or appreciate me for who I was. Okay. The most interesting thing in all this is that you're a student of neurobiology, and neurobiology is something dealing with the physical matter of the brain. So it's about the nerve cells and about neurotransmitters and other chemicals. And neurobiology has its own definition of what depression is and where it comes from. So what's the purely physical neurobiological definition of depression?
We have no idea. I mean, so, what would neurobiologists say causes depression? Me and Professor Moncrief have just been given a whole lot of letters trying to explain it to us. They say it involves chemicals, it involves nerves, it involves neurons, it involves, there's theories about inflammation, there's theories about neurogenesis, there's theories about growth factors, there's theories about overactive amygdalas and dorsolateral frontal pre-cortex under an overactivation. I mean, there's someone put on the internet the other day, there's 69 different theories of the biology of depression. So the honest answer is we don't know. The next most simple answer is people think it's something to do with the brain, and they have all sorts of different ideas about what that might be. They talk about dysregulated this system interacting with something else. We don't know. There was a time in my life where I was very intensely interested in those sort of questions because I thought that was the real science. That I sort of understood, of course, people's life circumstances and their thinking. There's a biopsychosocial, but really at the core of it, there's something biological happening, like there is in diabetes or in lung cancer. And so the reason why I, went to study the neurobiology of depression was because, I was influenced by what was around me in the culture. I read a book by Peter Kramer, who wrote, very convincingly, I think slightly too convincingly in retrospect, that we were starting to understand the biological structure of depression. I thought he was writing about inflammation and stress hormones and the growth of new neurons, and I thought, this is fabulous. I can understand myself, of course, like we all want to do, dressed up as professional work. I can understand my family if I can get down to what is the root underlying depression, and that's what I moved to London to study and do a PhD in it. And I was, very, very intensely focused on inflammation, stress hormones, and neurogenesis.
So when you were 21 and you were in the third or fourth grade at the university, and you felt anxious and depressed, and you went to see a psychiatrist, it was kind of
GP. So, but yes.
Oh, GP.
Yeah.
Oh, all right. And you got the prescription for antidepressants from the GP.
Yeah, in a few minutes.
Okay. Can a GP, within a few minutes, examine your brain to be able to decide what kind of dysfunction exists in your brain that causes depression?
So you'll probably know that 85% of antidepressants are prescribed by GPs, not psychiatrists. Most people will never see a psychiatrist who are on antidepressants. That's true in England, it's true in America. So, and I'm sure you know that they diagnose depression by doing a set of symptoms, not by examining people's brains.
Yeah. All right. So you got the antidepressants, and did it help you find life balance? Did you feel better?
I don't remember very well. What I remember is a lot of side effects. I felt a bit intoxicated. I'd used ecstasy, I think, a couple of times in my life before then. I felt a little bit like that. I had a strange yawning. So I had a lot of side effects. I remember feeling on one of the drugs slightly high and disinhibited for a few weeks. I went back because various side effects were unpleasant. So I don't remember exactly whether it overall improved my mood.
And when you go back to the doctor who prescribed the antidepressants and you say that you have some side effects or that you don't feel that the drug is working, what they usually do, they give you another on top, or they give you another one that should be working. Was this your case too?
So I asked to change the drug because I thought the side effects for the first one were a GP wouldn't generally add on top of another drug. They would probably try to change it, which is what they did with me. And I did that a couple of times, I think, approximately. And in the end, I just decided the last one also had some side effects, but I just decided I've tried enough. I'll just stick with this one. It's just easier to stay on this.
And I remember, and I loved what you said in one of the interviews, that you realize that the patients have a much bigger knowledge than the doctors, because the patients taking the antidepressants experience the withdrawal effects, and they know that you cannot just stop taking them, or that the withdrawal effects will disappear within 2 weeks. What did you learn from the patients about withdrawal effects?
But yes, when you talk about withdrawal effects, I think, until recently, maybe there's been a slight shift, but for many years, there was a lack of recognition of withdrawal effects by doctors, and you're quite right. I found a lot more help and a lot more insight from people in online forums than I did from doctors. So when I tried to come off an antidepressant, which was for the first time in a serious way, which was about 8 years ago now, I was finishing up my PhD at the Institute of Psychiatry, and I came off over about 4 months. I had very severe withdrawal effects. I was looking at the literature written by the psychiatrists that I worked with and the professors in my field, who all said that withdrawals, they call it discontinuation symptoms, a euphemism from drug companies, are generally mild and self-limiting over about a week. That's what the guidelines said. That's what the research said. I had nothing like that. I had extremely severe symptoms that lasted for month after month. Much more, if we go back to me as a neurotic Woody Allen-like character, that was a 3 out of 10 compared to what I had when I came off them, which was more like a 10 out of 10. I had panic attacks, which I never had before. It lasted for several hours of the day, couldn't sleep. I found descriptions of everything that I was having amongst other people on these online forums. And they repeatedly said the symptoms are much worse than people say in guidelines. It's much harder to come off these drugs than guidelines say. It takes a lot longer. And this coming off in a couple of weeks or 4 weeks or 8 weeks is much too short. And first of all, I found it a bit confusing that I was getting a lot better advice from peer support groups than I was getting from, the world experts, people around at my university. But very soon I came to see that they had a lot more insight into the issue than the experts did. And I'm someone from a very institutionalized background. I've spent my entire life sitting in lecture halls. I've done 6 academic degrees. I'm a completely institutionalized person. So, I found that quite jarring that there was so much better information online. And so I learned how to come off antidepressants from, a retired systems engineer who runs one of these websites, and for other people on those websites. And that's what I do now with patients. And it's also all the academic work that I've done since then is writing about what I learned from those websites.
I remember reading in one of the interviews, or maybe on your website, how your health was getting worse and worse. And how did you realize that these are side effects or withdrawal effects from it was side effects from the antidepressants you were taking, and they were making you more and more sick. So you were getting other drugs to help you with sleeping, with some physical ailments that you had. How did you realize it was all connected to the antidepressants that you were taking?
Yes, so it gets a bit confusing. Exactly, there's side effects from being on the drugs, and there's withdrawal effects from being on the drugs. It is confusing. So I had for many years had 3 major problems. One was daytime tiredness. I used to fall asleep during the day a lot. Troubles with concentration, trouble with memory. And
to the extent that you could not work, right? You stopped working.
To the extent that I'd moved to part-time work, and I was actually considering taking early medical retirement because I was walking around the hospital and I would be taking notes about everything that everyone had said to me, because if I didn't write it down, I wouldn't remember it. I was arranging to have neuropsychological assessment for early dementia because I thought this is completely abnormal. Early on, I'd had a brilliant memory, a near photographic memory being one of my, key tricks to be able to do well in exams. And I found myself completely, befuddled. I received various diagnoses for this. One was chronic fatigue syndrome. The one that stuck was narcolepsy, a sleeping disorder. And I was told that I had severe narcolepsy, and I was given a variety of drugs to wake me up, drugs to help me sleep. And I ended up on 5 psychiatric drugs that were prescribed by sleep physicians and then psychiatrists. And I guess the first thing that alerted me to it was when I was reading on these websites, people who were coming off antidepressants, a few of them mentioned that on the drugs, they'd become extremely tired and had trouble concentrating. And I thought, that was a little kind of green light went off that these people are having similar experience to me. I then found at some point along the way that there were surveys asking patients on antidepressants about their side effects. And a lot of them talked about being mentally foggy, having trouble with concentration, trouble with memory, and daytime tiredness. So I started to wonder whether it was being on the drugs that was causing this. It became clearer to me when I started coming off the drugs eventually, and some of those symptoms improved quite a lot. Daytime tiredness, concentration issues, and memory. So that now I'm working full time, even whilst actually withdrawing from the drugs. So I've had a lot of my capacities come back. So I'm going to be much more productive. I feel very grateful to be given the chance to have those, my mind back. And I can see in retrospect things that I, had attributed to other conditions were actually side effects of the drugs. And I think it's very common for lots of people, because if you're given an antibiotic and you become nauseous, you take it for 2 weeks, it's obvious what's happened.
Yeah.
Take a drug for years or decades like I did, it becomes very hard to remember how you were beforehand. I think some of these effects can come on slowly, so it's very hard to attribute it to the drug itself. And I think that I'm not alone in only working it out in retrospect.
So what would be, let's imagine someone being on antidepressants for years. What would be the signs that or the side effects of taking antidepressants that we should be mindful of? What should we look for?
So I think there are a few main side effects that are very common and affect people's lives. So number one is emotional numbing, which I certainly had. This idea that emotions in your life are flattened, both positive and negative emotions. Some people might experience that as a relief in the short term, that their emotions are numbed when they're feeling terrible. But the drugs are not so specific as to target just the negative emotions. They affect all emotions. People can lose, enthusiasm for life, their interests. It can affect
So you lose the ability to enjoy life. You lose some of the motivation for life.
I think that happened to me, and I think that's what people say. So the number one reason people give in surveys for wanting to come off antidepressants is emotional numbing from the drug. So it's a central thing. Sometimes people blame it as a symptom of depression. They say it's anhedonia from depression. Mm-hmm. There was a study done recently that gave people, healthy volunteers without depression, antidepressants, and showed that it produced emotional blunting in them. So I think it's a very good chance that it's
every second person experiences emotional blunting on antidepressants.
Yes.
One of the studies.
Surveys, that's about 50 to 70% of people say that. That's the first thing. I think the second thing is I now see daytime tiredness, memory and concentration problems are extremely common in people on antidepressants. Sexual side effects are reported by more than 50% of people on antidepressants. That's very common. I see a lot of gut problems. People get diagnosed with irritable bowel syndrome or things like that very commonly on antidepressants, because the antidepressants affect the gut. There's a lot of serotonergic receptors in the gut.
Serotonin. Yeah.
Trying to think of a
weight gain.
Quite cool. Yeah, sorry. Exactly. Weight gain is very common. There are studies that show that for people who are on antidepressants long term, there's a 30% increased chance of them going from being normal weight to being overweight, and a 30% chance of going from being overweight to being obese. So there's definitely, in the short-term studies that the drug companies favoured, in the first few weeks, there was very little in the way of weight gain, but over years, you can see it more clearly. So I think that's one of the issues for people.
And trouble with sleeping?
Or
sleeping overly, like you had narcolepsy or something that looked like narcolepsy because you were so tired and sleepy all the time.
Yeah. So it's an interesting point. Antidepressants, in all the studies that have been done, disrupt sleep architecture. They vary, we have stages of sleep, REM. It's well known that they will prevent REM sleep, which is why a lot of people don't dream while taking antidepressants. But if you look at studies, they interrupt people's sleep, they cause more awakenings. I guess that's why they might impair concentration and memory, because if you're having less restorative sleep, you may be tired during the day, and you may also have not consolidated your memory as well as possible. So daytime tiredness and impaired sleep and insomnia are all recognized side effects of antidepressants.
I have listened to an interview today with a Polish psychiatrist who said and stressed that antidepressants are modern drugs which are safe to take and do not cause addiction. What would you say about that?
So I agree with him that antidepressants are not addictive, because people don't crave antidepressants. They don't snort antidepressants. They don't rob from their neighbors. But there's another issue, which is physical dependence, which antidepressants definitely cause. So this term causes a lot of confusion because the terms dependence and addiction have become conflated. That's because the DSM-3 committee chose to use the word dependence rather than addiction, because they thought addiction would be stigmatizing to people with abuse issues with drugs. The problem with that is that physical dependence in pharmacology refers to the predictable physiological adaptation to a drug that occurs if you take a drug repeatedly. So, for example, I'm sure everybody, including me and you and everyone in the audience, is physically dependent on caffeine. You drink coffee every day. You don't steal from your neighbor to get it. You don't snort it. You're not abusing it. But if you stop it, you get a withdrawal syndrome. The same is true for antidepressants. If you use it for long enough, you develop physical dependence, and that puts you at risk of having withdrawal syndrome if you stop it. So while it's true, I agree with with the Polish psychiatrist that it's not addictive. It definitely causes physical or physiological dependence on the drug, which sets you up for withdrawal when you stop the drugs.
The withdrawal effects would not last 2 weeks, like we said before, but it may take years to come off the drugs.
So I'll tell you a bit about what we know about that. So the statements favored by drug companies and the academics that work by them relate to studies that show that studies of people who are on antidepressants for 8 weeks. So drug companies, after doing their trials to show the drugs work, the regulatory bodies take people off the drugs after 8 or 12 weeks use. And it's true that most patients have mild and brief symptoms after that period of time. But what we've also shown is the longer you're on the drug, the more likely you are to have withdrawal symptoms, and the more likely they are to be severe. So by the time people are on the drugs for more than 3 years, more than half of people will have withdrawal symptoms, and more than half of those that have withdrawal symptoms will say that they're moderately severe or severe. So there's a real gradient. So it's very misleading to say that antidepressant withdrawal effects are brief and mild, because that's only true for people that are on them for a few weeks. Most people out in the community are on them for months, years, or sometimes decades. In America, more than half of people are on them for more than 5 years. It's less in Europe and England, but starting to move towards there. Withdrawal symptoms can last much longer than a month. They can last for months or years. People find that strange when they first hear that, because the drug leaves your body in a few days or a few weeks. And people ask, how can it last for months or years? Mm-hmm. But the effects of the drug on the brain can last for months or years. So we can see after just a few weeks of antidepressant treatment on neuroimaging that people's serotonin receptors become less sensitive. And we also can see that after people stop the drugs, that change in their brain to the serotonin system can persist for months or years afterwards. The same has been shown in animals. And because your brain is less sensitive to serotonin, it can give you all sorts of withdrawal symptoms, because the level that your brain expects and what the drug is present is different, and that causes withdrawal symptoms. That's why they can last for so long. We don't know how many people will have these long-lasting symptoms, but it seems to be a sizable minority of people.
So the antidepressants, even including the latest generation antidepressants, they physically change the brain.
Yes, it's not possible to take a drug that doesn't change the brain. If a drug, the principle here is homeostasis. So we like to be in the middle. When it's very hot outside, we sweat. When it's cold outside, we shiver, because we want to keep in the middle of things. When you give a drug that increases a chemical in the brain wants to bring things down to normal, and so it will down-regulate that system. So in the same way, if you're in a loud concert, your eardrum will become tighter, so you hear things more quietly. When serotonin is increased by a drug, the brain will become less sensitive to serotonin in order to balance things out. The problem is that change can persist for a long time after the drug is stopped. So an example is you're in a loud concert, too much noise, your eardrum down-regulates, so you hear less noise. You walk out in the quiet street and everything sounds extremely soft because your eardrum is still adapted. It takes a while for it to get back to normal. The same happens with serotonin, only it can take months or years for the brain to get used to the fact there's less drug about, and that's why you can get withdrawal symptoms that last for so long.
I think there is also one more thing to say about what the psychiatrists say about the drugs. Where do the doctors find out about how the antidepressants work, whether or not they are safe? Do doctors carry out some clinical studies, or who does the clinical studies, preparing a set of information that is being given to the public and the doctors?
So most of the information that is in the guidelines that doctors read comes from studies done by the manufacturers of drugs. So more than 95% of studies of antidepressants and similar drugs are conducted by the manufacturers of those drugs. And the manufacturers do studies that meet the requirements of the regulators. And for most regulators, that means doing studies that go for 6 weeks to 12 weeks that show a difference from placebo to a statistically significant degree. And that's what formed a lot of the published information about these drugs, and that's what is imported into guidelines. So, as you're suggesting, there's lots of limitations to such studies. So, a lot of these studies are very short term. So, they're 99% of studies for antidepressants go for less than 12 weeks, which means that we don't know what happens in the long term with these drugs. They show extremely small differences from placebo that most people don't think reaches a clinically important difference. So kind of like if you showed that a weight loss treatment was better than placebo, but it only made you lose weight of 50 grams, it's not to a clinically important degree. The studies tend therefore to exaggerate the benefits of drugs and to minimize the harms. There's a drug regulator who says that drug companies use a magnifying glass to look for benefits and a quick glance to look for negatives. So then because a lot of the leading academics who work in this area have relationships with drug companies, and more than that, because a lot of the integrity of academics in the area is bound up with the drugs. So the key issue, the key thing that separates psychiatrists from therapists or social workers or anybody is their ability to prescribe drugs. So it's their USP, it's their unique selling point. And that means that doctors and psychiatrists and psychiatric drugs are very intertwined. So there's a lot of senior academics who spend a lot of time defending the drugs because that is their, that's what their authority and their jobs derive from. That leads to a lot of papers that skew the benefits of drugs in a positive way and undermine and minimize the negatives. And that influences things like guidelines and prescribing practices. So unless an individual doctor is putting in a lot of effort to look at the science directly, to look at it through a critical lens and look at what the slates of hand, the tricks are, they would generally get an overly rosy version of what these drugs do and an overly rosy version of the side effects and also the trouble coming off the drugs.
So let me see if I got it right. The clinical trials of the drugs are being done by pharmaceutical companies. They're not being controlled or verified by an independent institution or some kind of body.
There will be some oversight in the studies. They'll report to a drug monitoring board. There's various oversights, but it's not my area exactly. But there's been lots of criticisms that such things don't work. That there's all sorts of ways that you can change the outcome that you're looking at, that you said you would look at. You can change the outcome. There are ways of setting up things so you find what you want to find. There's all sorts of tricks that the drug companies do. It's always the regulator is chasing behind the drug companies to try to work out what is the latest trick. So yes, we know that studies done by the manufacturer of a drug are much more likely to find a positive outcome for the drug than if it was done by an independent researcher. So yes.
Do they publish all the clinical trials or only the clinical trials that prove their efficacy?
So exactly, there's a huge issue with publication bias. There was a study done, a famous study done about 15 years ago now, where if you look at all the published studies on antidepressants at that time, the vast majority, 90% of them were positive for the drug compared to placebo. When the researcher, Eric Turner, asked the FDA for the unpublished data, actually it was half. Half of the studies showed antidepressants were better than placebo and half showed that they were the same. so that studies that were negative for the drugs were not published, and even studies that were negative were actually spun to make them sound positive. So yes, there's a huge issue with publication bias, and of course, companies can choose not to publish studies that are unfavorable to their drugs.
You already mentioned the difference between a psychiatrist and a psychologist or a therapist. And if you were 21 again, feeling the same way you felt then, because let's first explain the difference. A psychiatrist is a doctor who can prescribe drugs, so has a
diagnostic framework
Yes. So when a psychiatrist sees a patient, tries to find what's wrong with the brain of the patient and prescribe drugs. So a psychiatrist not necessarily is trained in understanding emotions the way a psychotherapist or a psychologist is trained. Is this correct?
Look, it depends on the training. It depends where you are. Psychiatry training involves learning about therapy and also about, neurobiology and about medication. So where I trained, we were taught psychodynamic psychotherapy and cognitive behavioral therapy. It varies in different places. I think in practice, because of constraints and because of, I guess, the sort of ideology in which people are swimming, it tends to be that biological treatments are prioritized depending on the condition for a lot of different treatments, for a lot of different conditions. And you're right, most psychiatrists are thinking through a diagnostic framework, like other doctors in other specialties, as to what is the underlying problem. And I think the implication is it's often biological. There's a lot of discussion about it being biopsychosocial. And of course, most doctors and psychiatrists will take into account psychosocial aspects. But I think you're right. The diagnoses in the DSM or the ICD are not specifically called brain illnesses, but the implication is that they are, because that was what I was looking for when I did my research. What is the biological basis for these conditions? Yes, life problems can lead them there, but what is the thing that changes? Yeah. Like with diabetes, it's eating and what you're doing that affects them, but ultimately it changes things down at the bottom level with insulin. And so I think, yes, you're right, that underlying this, it's bio in capital letters, underlying psychosocial in small letters. And so I think you're right that most psychiatrists are seeing things through a diagnostic lens, find the right diagnosis, match it to the right treatment, and you'll treat things like you would with a bacterial infection. And like you're suggesting, if I was 21 again, I would much prefer to go to someone who would discuss, what the existential issues were in my life, rather than see me as a faulty brain walking around in a body.
Do you think that antidepressants are safe to take?
It's a very difficult question to answer. I think antidepressants are drugs that have a lot of different side effects, or side effects I think is a bit misleading. It has a lot of adverse effects, a lot of harms. We've talked about a few of them on memory, on sleep, on sexual function, on weight. It depends on how you define safe. It's safer than some drugs, that can cause, that are used often in physical health medication that can cause, your hair to fall out or very significant side effects. So I think there are more, but I think there's definitely more harms and more dangers to the drugs than most people appreciate. I think taking that into account compared to the very small effects they have on mood in the short term, that there's generally an unfavorable balance of harms and benefits to antidepressants for most people. And so I think that as a result, we should be a lot more cautious with prescribing them. And sometimes I wonder whether, given all the harms, including coming off them, the fact that any beneficial effects probably wear off over time because of tolerance, I'm not entirely sure who they would be best used for.
What about long-term use?
So I think long-term use is particularly worrying for a couple of reasons. One, the studies that are said to to show that long-term antidepressants are useful are studies in which they take a group of people on antidepressants, they divide half to stop the drug and half to continue with the drug. They measure depression symptoms for the next 12 months, and they show that people who stop the drug do worse. But none of those studies take into account withdrawal effects. Yeah. So, I think they're mixing up withdrawal effects with depression. It's a little bit like taking people off cigarettes and saying, look, they're a lot more irritable and anxious, therefore they must need to keep smoking. And so I think that the evidence that long-term antidepressant use is based on is very flawed. I think long-term antidepressant use causes a huge number of trouble for people. I've just mentioned a whole lot of sexual, weight, concentration, sleep. I think if they are to be used, antidepressants should be used in the short term. I see them, I think that informed consent for taking antidepressants would explain to people, we don't understand the biology underlying depression. There's very good evidence it's caused by stresses in people's lives. Most people will get through it. Recovery rates for depression over several months, is 85% plus, even more for mild depression. So most people will get better by themselves. Mm-hmm. Antidepressants have a very minor effect compared to placebo. We don't know if that effect is even as big as we've found because of the way that drug companies conduct the studies. The effects normally wear off over time. There are lots of side effects. They probably work by numbing people's emotions. If that is useful, it's probably useful in the short term because it can cause all sorts of trouble in the long term. Do you want to try that medication? I think that would be an honest, informed consent. And if people want to choose it because they're desperate, at least then they might think about using it in the short term rather than the long term.
So how long were you taking antidepressants?
So I'm still taking antidepressants. I've been taking them for 20 years. I'm in my fourth year of tapering off them. I ended up on 5 drugs. I'm down now to 2 drugs. One of them is almost finished and one of them is close. So altogether, I've taken them for 20 years.
Is it difficult to come off the drugs?
It has been very difficult to come off the drugs. So I've tried in a serious way on 2 occasions. Once, I mentioned 8 years ago, I tried to come off over 4 months, and it was probably the most distressing period of my life. As I said, I developed panic attacks that lasted for most of the day. I had trouble sleeping. A few weeks into that experience, I thought about killing myself because it was just waking up to the same horror every day was unbearable. This time, I've learned a lot since then. I've taken a much more cautious approach, and I've been coming off according to a hyperbolic taper by a small amount every few weeks. I've tried to fit it around my work. I've been very busy the last few years. Perhaps I could have gone quicker if I hadn't been so busy. It's been an unpleasant experience coming off, but not nearly as unpleasant as it was several years ago. But it has been, a very difficult position. It's disrupted my life in many different ways. So it's been very hard to come off.
I know that there are probably no official sites guiding how to come off the drugs. And there is a huge subculture of underground people who were taking antidepressants and are trying to come off and share their experiences, how to taper. So, of course, you cannot just stop taking them because the withdrawal effects may be very dangerous, right? So if you could advise someone who has been on an antidepressant for months or years, how should it be done properly, the tapering?
So I'll just first say one thing. So in England, there's been a lot of progress on this issue in the last 5 years. And there is new guidance in England from the Royal College of Psychiatrists. People can search for that, stopping antidepressants from around the world.
Officially. Amazing.
Yeah, it's exactly. It's been a lot of pushing, a lot of argument. The NICE guidelines who direct treatment in England also have changed their guidance to suggest people come off very slowly in smaller and smaller doses. So in England, there is a change in guidelines. In countries around the world, in Europe and America, there's been no such change in guidelines. Mm-hmm. And you're right, a lot of people go to these peer support sites to get advice. In general, there's 3 major principles to coming off antidepressants. One is to do it slowly. So it generally, if you've been on it for months or years, like I've been, You can't come off in weeks. As you say, it's too dangerous. You can come off often in months or sometimes more than a year, sometimes a few years. You need to go at a rate that you can tolerate. Everyone's a little bit different. Some people can come off in a few months. Some people it takes longer. You should adjust the rate to whatever you can tolerate. And then an important issue is to come down by smaller and smaller amounts. And that's called hyperbolic tapering or sometimes proportional tapering. And it's because very small doses of the drug have very large effects. So rather than there being a straight line where doubling dose doubles the effect, actually there's a hyperbola where extremely tiny doses of a drug have very large effects. So for example, 2 milligrams of a drug, which sounds like a very tiny dose, can have half the effect of 60 milligrams. And that means when you get down to lower doses, you have to go down much more carefully. It's like walking down a relatively shallow path that then turns into a cliff. So you've got to go down by small, you've got to climb down that last little bit. And that involves going down. Some people might go down at 20% of their last dose every month or even 10%. And the important bit at the end is to use a form of the drug that it can allow you to make these small changes using either a liquid version of a drug. Sometimes people can get smaller tablets made up for them, and that allows people to inch off those last few milligrams, which can be the hardest to come off.
I've heard of people using nail files to powder the drug and using a pharmacy scale to weigh the round amount. So it's been 4 years for you. How long do you think it's going to take?
I'll just say one thing. So we're about to release a textbook on how to stop psychiatric drugs. There's a variety of different ways that you can make up the smaller doses. That's a very key issue with things. A lot of drugs will come as a liquid from the manufacturer, and that makes life very, you can use a small syringe and you can even dilute the liquid to make up smaller doses. You can crush a tablet and put it in water and shake it and use that. That's commonly done in medicine. There's even videos on how to do it from the National Health System, from the NHS. The filing and weighing is not generally recommended by pharmacists. I think it can be difficult to get a balance that weighs that's accurate enough, but people do that. And there are also pharmacies that can make up for you sometimes liquids or smaller tablets. For me, it will probably take me another year or year and a half to come off my drugs. So it'll all up take me about 5.5 years, probably. To some degree, it's been slower because I've been somewhat distracted, busy elsewhere. But of course, when I started the drugs at the age of 21, I had no idea it would take me 5.5 years to come off these drugs. And really, in some ways, I've been trying since 2015. So it'll almost have taken me 10 years to get off the drugs. So I was not given informed consent for these drugs. I was not told these issues, and it's disrupted my life for years. So it has been a huge burden in my life, one that I never expected.
Do you feel like you are yourself already, or do you wait for being totally clean of the drugs to know who you really are?
I think it's sort of incremental. I mean, there's a combination of things. When I'm on less of the drugs, I've got less in the way of side effects. But as I'm coming off, I've got withdrawal effects. So it's a little bit, the picture is a bit complicated. I think on the plus side, I'm definitely less tired during the day. I'm definitely, better able to concentrate and to think, which has been, a real pleasure after spending years thinking I've just lost my ability to think straight. I've just lost, the intellectual capacities I had as a younger person. Getting that back has been very gratifying. I still have a lot of withdrawal symptoms as I'm going through the process. So I still, as you're sort of saying, the smoke hasn't quite cleared yet as to what's underneath. And I'm, a bit eager to find out, to connect to parts of myself that have been a bit numbed.
That's amazing. So last question. If we could go back in time, and now you are a doctor, and you see a young 21-year-old boy, anxious, because, he feels different and misunderstood and lonely and afraid of what future might bring. What would be your advice to him, and what would be the treatment?
So I would have said to myself, or to this mixed up young man, I would have said, there is no magic bullet for existential questions. The questions of, who you are, what you should do. There is no shortcut. There is no tablet in my drawers that can help this. It's the first thing to know. The only way through such problems is through them. There's no way around. I often tell patients that I see now, there's a study that followed people, a random sample of 1,000 people born in a certain hospital in New Zealand. It followed them for 45 years. And by the age of 45, 86% of them had met the criteria for mental illness, mostly depression and anxiety. In other words, it's a near universal human experience to be anxious or depressed, unless you have some kind of incredibly charmed life. So I said it's normal to feel disaffected. There's a very rich tradition of young people that have felt the same way, and they've written books and they've made movies. If you're thinking you need to change every aspect of your life, then maybe you should try that, because at the age of 21, you can do that. Maybe it'd be worth talking to someone about it. A sympathetic ear can make people's whirling ideas a little bit simpler when spoken out aloud. But I think the main thing I would have said is what I say to people in the emergency department when I see people who come in suicidal. I say, don't be, this is an understandable response to things in your life. It's meaningful. It's telling you something is wrong with what's going on. It's important. In the same way you wouldn't cover up a warning light on your car dashboard. It wouldn't be ideal to cover this up with medications. And there'll be a lot of people that will offer you diagnoses with capital letters that'll sound very serious, but don't lose sight of the humanistic, obvious, understandable reasons why you're here. It's working out that will get you out of this. Those are the sort of things. And I try to use, non-diagnostic language. People are demoralized, people are lonely, people are alienated, people are frustrated. It can drive people to be suicidal. I think that's much more useful, because if you're demoralized, the solution to that is to be remoralized by a positive experience in some way. Whereas depression, now you're talking about medicine and biology and brains, and that really,
kind of being sentenced.
And it also implies that there's going to be a chemical or biological solution to things. So I think it's good to keep things in the human realm and use that sort of language.
But we also say to this 21-year-old anxious and fearful of the future, could we say to him, look, this is amazing. You have a million choices in life. You can see the million choices, and this is what's making you anxious. It's understandable, but you have the right to choose, and you have the right to build your own life and find out what is good for you. So how about trying to make one small step towards a future that you would imagine for yourself? Would this be helpful?
It may have overwhelmed this young man already confused. And I'm sure you're right. I guess it was also the number of choices was part of what was troubling me. Look, I think it would have been helpful to do what you're doing, which is formulating the problem in terms of the common issues that strike young people, which is all these existential issues about choice. And of course, every choice means you can't do something else. So I think what was most helpful to me back then, I think, was normalizing things, was appreciating that other people had gone through similar experiences and got through it. That what I was experiencing was not so unique as we like to think sometimes, and putting it in a broader context as you're trying to do. So yes, I think that would have been helpful for me.
Thank you. Thank you very much. And I hope your life will get back to the best possible outcome, and you will not be worried anymore about tapering or anything else.
Yeah. Well, I mean, one thing I'll just point out to close, going through coming off these drugs and the trouble it's caused me and the near, life-ending trouble, the troubles that I had at 21 look piddling to me now. So, in a second, I would ask for double of that compared to what I've gone through. So if there is, I wouldn't wish it on anybody, if there is some lesson from coming off these drugs, it has made other negative things in my life look, minor by comparison.
I see. Thank you. Thank you very much. Thank you and good luck.
Thanks, Peter. Lovely talking to you.
Thank you.